Okay. I'm talking about subscapularis augmentation plus banca repair. It doesn't. I hear. Okay. This is a surgical treatment that has been began in 2010 because I just was reading this book of Lenny Johnson. He stated that with the bad capsule, bad ligaments, it was intelligent to use the superior part of the subscapularis tendon. But he used to fix it with the metal staple, as I will see you. And then a guy in Greece, Maiotti, studying about the putyplatis, says that after several dislocations, there was an elongation of the tendon. And so if you have an elongation of the tendon, post-traumatic, and then I will see that maybe the elongation could be constitutional. A simple banca repair, no matter what the patient does, you can have higher redislocation. Lenny Johnson was using this kind of fixation, the staple, and the staple mobilized. He was using this even for banca repair. Some of them maybe can remember. According to this technique, I thought to do the same thing, to use the upper third of the subscapularis tendon, fixing on the glenoid neck and using this kind of fixation. Before I was using a fiber tape with a push lock. Now I use a labral tape, and in the future we are trying to use, and we are beginning to use simple tape, anchor tape. Right now, after like 9 years, quite 800 procedures have been done with this, and in these different centers. And maybe, of course, I forgot someone else because it's impossible to involve everyone. But I think that slowly, like new philosophy, this kind of option is going on, and so we will see in the future. I want just to show an animation. How is the technique? You always try to perform a bank, reattach the capsule, even if it's a bad capsule, and then you penetrate the tendon. In the next presentation this afternoon, I will show you exactly how to do the technique in a better way. But anyway, you penetrate the temple with a tape, and then you pass the tape in the other cannula, you do a loop, you pass the loop in the highlight of the anchor, and you fix the anchor. Here is at the equator at 3 o'clock, but you can, and I will show you, usually can fix it even upper at 2 o'clock or even at 1 o'clock if the subscapularis tendon is in a certain situation. We have had many articles. This is one of this multi-center study with we took care about external rotation. We did see that after a good physical therapy, you don't have different external rotation in comparison with other technique, especially when the arm is in abduction, and especially when you treat shoulder that have monosegmental hyperlaxity. These are the results. And these are the articles that we have published, one on the journal Shoulder Elbow and the other one on arthroscopy. And another thing very important, we are publishing this review, and we have seen that with the Savinson mesuration classification, we saw that there is no arthritis in mid-term results after this operation. And then, according to the colleague that was talking before about failed banca repair, or banca repair that I used in not proper way, that they gave subluxation, I want to show you this case. This is a guy that has been treated when he was 19 years old, hyperlaxity, subluxation, 5 dislocation, sports guy. They did a bunker repair, and after 2 years, he had resubluxation, and he didn't want to have any other surgery because they told him that with physical therapy he could handle this problem. And this is his situation, and he is 27 years old after a bunker repair that was used in a not good way. So the other technique is not a putty-plug. This is very, very important, and people in history says that were afraid to use the subscapularis tendon. Even they didn't look at it when they went in the joint to perform a stabilization. And but we have no longer to be afraid. We are no longer afraid to use the subscapularis tendon if we know when to use it and how to use it. Now, after many years, there are other friends of mine, shoulder specialists, that have been studying this kind of indication, and we have arrived to this position. When we do ASA, in hyperlaxity monosegmental athletes, young people, especially, of course, they don't have not to perform throwing. They should not be throwing athletes, but contact sports athletes, young athletes, hyperlax monosegmental, with a bone loss less than 10%. But the bunker repair is a failure. And I show you, this is the guy. Or we can perform, this is not the main indication, when they have a traumatic dislocation, when the capsule is no good. This is very important. Look, this is the hyperlax guy, 5 dislocation. If you traction the subscapularis tendon, you have a traction. I will show you again. You see, 1.5 centimeters, the subscapularis goes there. So this is a hyperlax subscapularis tendon. This is a traumatic instability, dislocation. If you go to traction to afford a traction on the subscapularis tendon, there is no elongation. So go there, check in hyperlax people, traction, make a traction to subscapularis tendon, and you will see that the subscapularis tendon don't behave in the same way when the guys are young and hyperlax. This is one example in a clinical setting. You can see hyperrotation, no hyperlaxity of the hand, so it's a segmental hyperlaxity of the shoulder. We perform a tenodesis, and you can see that there is no hyperrotation after the tenodesis, but the rotation goes to normal with the arm adducted and with the arm in abduction. What do you see after MRI? You can see that after the tenodesis and the augmentation, the interval is closed. And so there is a reduction of the space. But you don't touch the interval, you only fix the tendon up on the glenoid neck. And so we have to study more to understand how it exactly works, but it works. And we think that in the remodeling process, this kind of augmentation reinforces the coracohumeral ligament and improves the healing of the tissue that you reattach in the inferior glenoid neck. You can see one function of the coracohumeral ligament is to avoid the inferior displacement of the head. And I think that we think that this surgery can help this ligament to scar and get stronger. And in fact, we did a biomechanical study that is published that in comparison with bunker repair, the ASA technique the other technique doesn't affect greater than bunker repair in anterior and anterior inferior translation. It's like that. Oh, and the other thing, this is not tested, that we think that putting a barrier on front, we act, and in this you can see arthroscopically, you push the head posteriorly and you act in the opposite way of the remplissage, because the remplissage, the main effect, I've done many remplissage before, the main effect of the remplissage, we think, this is not filling the hole, but it's pulling the head posteriorly, and then changing the direction of the axis of the humeral posterior and neutralizing the heel sacs. This is a second look. This guy has been operated at many dislocations, and then after the other technique, he has a big trauma with the scooter, had pain in the shoulder, so we went inside. This is after the first surgery, and then after a second look, you can see that there is a big, strong anterior ligament that has been restored. Now you see here you see big, strong anterior ligament and a big scar tissue on the supraequatorial space that depends on the tenodesis, and he had no redislocation at all. You see that the head is recentered. So we think that we see, now they said you need a bunker plus, okay? You don't. It's not enough only a bunker. So this is a bunker plus, and it's an available option in patients that are young, sports. You go there and you see that with the clinical setting they are hyperlax. You go, you do, and you make a traction to the subscapularis tendon, and you see that the traction is positive, 1 centimeter. Or you can use it if you want when the capsule is no good and you don't know what to do exactly, instead of doing a bone block or a lattaché. Thank you very much.